what is palliative care, and does it have a role in goals and quality?
Yes. So palliative care is a medical specialty designed to provide the best quality of life possible for people facing serious illnesses. The way that I describe it when I talk to people is I want to make sure my patients are comfortable and that we're doing things for them and not to them. And that lands for whether you've got somebody with a 7th grade education or you've got a college professor. That lands because that makes sense. You could probably ask 10 people what the definition of palliative care is, or look it up online and you'd get 15 different definitions. So I tend to do that because for me it's really working on the patient and their life, their goals, and then working out rather than kind of saying we got a diagnosis and we're working in and this is what we're going to do, which is kind of the typical medical model. But I'm an internist by training, and so it's very medical, but it's also balancing the risks and benefits of any treatment option, whether it's an aspirin or it's a ventilator.
Mm-hmm.
We all have to do this.
Care.
It's still care.
It's still care. It's not it doesn't have to be an invasive procedure or chemotherapy, an operation, but it's still care.
Right, and that's the one thing that I wish we as a medical system would get away from is withdrawal of care. That's like the worst phrase I think I can. It's one of the worst phrases. I hate it because in fact the caring, in my experience, sometimes goes up when tubes and lines and things are removed. The care really it's pretty intense.
Tell us a little bit more about withdrawal of care. That term I hear a lot at work. And families are asked to surrogates. Maybe their loved one is not able to communicate, and so they encounter this phrase. Explore that a little bit more. I think that might be helpful.
Okay. So really, withdrawal of care comes from situations where any care intervention, whether it's IV fluids all the way up to ventilators and blood pressure medicines to keep your blood pressure up, or even other machines, kidney machine, dialysis machines, ECMO, you may have heard a lot about with COVID. Really, it's where the medical team gets to a point where they're saying, this isn't helping anymore. This is not helping, and that chance for recovery and life beyond this is not there anymore. And so you get to a place where you have to talk about, you can keep people going on ECMO and things like that for a long time. I mean, months, maybe even years, theoretically. I think you could. Most people, I don't think, would want that. But it's more about de-escalating care is what I call it. Or I like to call it either transitioning to a more comfort-focused approach. A lot of these gadgets, gizmos, invasive things that we do are not super comfortable. And if they're not making you better, well, then we're just getting the side effects without the benefits. Yeah. And so I tend to prefer either comfort care or allowing a natural death. I really like that phrasing better than withdrawal of care because for me, my care increases when we take a lot of the machines and things away and the interventions away, because that's when you're with folks during really, really tough, important times in their lives.
I think this is so helpful because, to prepare for a test or a treatment, sometimes it's withholding their cup of coffee and their breakfast. It may be providing a treatment that has some level of discomfort. At minimum, you're still on a table for a period of time. And so I think it's helpful to ask, again, what is the expectation that how will this treatment impact a person's health, their quality, their goals? If they're not congruent, then it's not really an option. But I think there's a disconnect in some of the medical community who will focus on their tree, but yet the whole forest is in trouble. And it's easy as a specialist, I'm a specialist, and it's easy for me to focus on just my particular specialty and talk to a patient and to a family, but ignore a more critical problem. And I think this comes up a lot. And at some point, I appreciate you and your team so much how to help identify, this patient is struggling and they may not improve. They're not going to improve. And do we continue to do these things that may provide discomfort with no benefit.
That for the patient, not to the patient, I feel like it's just key.
It's a
in
huge
that whole
distinction.
discussion. That's great to hear you say that.
That's the best way I've come up with to describe what I do. Because if you talk about, well, I help people fill out advance directives,
Right.
But people are that makes sense to them. And again, it really, all education levels, backgrounds, people get that. That just kind of makes sense.
Mm-hmm. Okay. What is that?
So hospice is a subset of palliative care. So if you have a pie chart of a patient population of palliative care patients, there's going to be a subset that's in hospice. Hospice is a Medicare program. It's funded by the government. It's designed generally to provide care for people with a prognosis of 6 months or less by a doctor. I tell you how I do that, just so you know. I don't know the future. Most of my peers don't either. Eric might, I don't know, but the average doctor doesn't. But the way that I do it is I say, if I've got somebody with a set of conditions, if I have 100 of those people, can I say that half of them would not make it past 6 months? And if I can say that, you qualify for hospice. What I haven't said, though, is you're going to die in 6 months. That's a key distinction. And really, in my work, I don't care as much about your prognosis if I'm recommending hospice for you as I do what kind of care does this person need. Mm-hmm. Is it more hospital? Is it more aggressive treatment? Is it more invasive stuff? Or do they need to be at home with their family, focusing on being comfortable, because these things are not helping them anymore? And so that's really, prognosis is an important part of it, but really it's designed to be caring for the people who care for the people at home. So it's almost, it's an older model, and a lot of modern family dynamics and culturally don't fit that because, well, I live in Tennessee and mom lives in Arizona or Florida or vice versa. And it's not like, oh, well, we all live together like we used to and dying at home. And so, it's harder for people to do that at home. Hospice is generally a team of nurses and healthcare techs that come to your home. They'll come a couple of days a week to visit you for a schedule, so they're not around the clock. That's another thing that's important to know about hospice, because a lot of people are like, oh, so they'll be there the whole time, and no, they won't. And so that has implications about who gives medications and things like that. There's a lot of wrinkles to it. But hospice in general is designed to be a way to support patients and their families towards the end of their lives at home. But I will say it's also not just for the immediate end of life. Historically, hospice, they're bringing in hospice, and we've even seen this, in the media recently. Whole towns are, on vigil because somebody went to hospice. People can live for years on hospice. Doctors are wrong sometimes. Mm-hmm. I know that may be hard to hear, but we are wrong in it. So
there was a family member of my wife's who was in hospice for I think over 2 years.
Wow. Yeah.
Mm-hmm. Yeah, I've had several patients. The longest I think I've ever heard was 5.
So it's a different type of care.
But it's still care.
Yes.
I think that's a key distinction that we all have to wrap our minds around. It is not abandonment.
Yeah.
It's care.
Yeah.
It's just care appropriate to that person's goals, wishes for quality, and for whatever illness that they have.
Yeah. The goal of hospice, the way I describe it is, it's to keep you comfortable and to keep you where you are. Mm-hmm. So it's they're going to do whatever they can for you where you are, but they're not going to throw you in an ambulance and say, hey, let's go to the ER and figure it out.
Right. And so I remember years ago, unfortunately, my grandmother had a cancer, a terminal illness. I mentioned the word hospice. And so being a member of the Little Baptist Church in Georgia, she said, well, I'll never consider hospice. And I didn't understand why. And so as I was learning about it, she said, well, everyone that she knows goes to hospice. Will they just die? And the thought by she and her friends at church was that patients were euthanized in hospice.
Oh, wow.
And so it was an opportunity to have a conversation about, okay, exactly what does that mean? what are the goals of hospice? What are the goals of end-of-life care? And unfortunately, when it came for that time for her, she chose hospice, and everyone else in the family, along with my grandmother, we all benefited from it. What saddens me sometimes is I feel like hospice is chosen appropriately, but too late.
Yes.
And so my hope with having these conversations is recognizing that it is still care.
Right.
And that if you're like my grandmother's friends, when someone's in hospice for 2 or 3 days and thinking that they're euthanized, that's not what can happen with hospice. It can be a long time.
It can.
But it helps to support, comfort symptoms and address concerns and still be care.
But also support for your family. And I
Yes.
think that's a big selling point for me, is it's not just for the patient, it's for family members, guiding them through that process and through that journey, because it's a process, and the hospice workers in general are angels on earth, in my opinion.
Yeah.
They do it because they care. They don't do it, because they make a lot of money or get a lot of recognition.
Right.
So
Why do you think it's late sometimes?
for that very reason, because of the euthanasia, the people, everybody that goes on hospice dies. I know, I always called it, 10 milligrams of morphine in a cloud of dust, it's just, you give a big dose of
Right.
morphine and that's it.
Yes.
And so, and historically, even up until probably some places 10 or 15 years ago, that's what it was.
Yeah.
And so I have a hard time sometimes telling people, you can be on this for a long time. You may live longer than we say. We tried this treatment, it didn't work.
Yeah.
We may be wrong about something else,
Yeah.
And so, but that's one of the hurdles that's really hard to get over and I think also psychologically, the H word just has a lot of, it's loaded for people. When when I say hospice, you can feel the change in the room. And so.
Do you think it's loaded for their doctors?
Yes. Yes, because it means I can't, the things that I do are not effective. That's what it means in the way
Yeah.
that I want them to
Yeah.
be.
And if the drive is to do, then to stop doing is somehow to.
It's countercultural
Yeah.
almost.
Or not necessarily stop doing, but do something differently.
Different,
Yeah.
right? Yeah.
Yeah.
But I think for the average person, hospice is one of those words that it denotes
Yeah.
end of the line. Like
This
it's
is it.
last step, right? And I think that's what you're wrestling with there, is this idea that people automatically think you're sending me home to die.
I'm in my last few days of
Right.
life, and
Right.
that's not the case. And if somebody says it is, that's not accurate. And if somebody from a hospice says that, use a different one.
But the timing
Yeah.
issue that you brought up,
Yeah.
Eric, I think that's why, right? Because we've seen it happen so late, so many times, that I think the overwhelming sense is that, oh, well, that's what we see. We see people go home, they get on hospice, and they die. And the idea that it could be different from that is, I think for the average person, it's novel.
Yeah.
Yeah.
So,
Is there some type of counseling or education with family members when someone does enter hospice care and goes home? Is there some kind of education, counseling?
Yes,
something
most hospices have a chaplain and then either a social worker or a psychologist, depending on the size of the hospice and the resources available. Most have some capacity to provide emotional support and also guidance. The nurses generally are really, really good. I in my training, I got to go out with the nurses and just kind of see what they did. And I learned so much about prognosis, about how to say things, about what to say, when to say it, what not to say. It really is, it's powerful and good. And for the overwhelming majority, for nurses they just walk families through that process, because they see things and they say, this is what it looks like, and this is what we can expect moving forward. These are the things to look out for. And that's what I do in my work a lot of times. It's like, this is what it's going to look like, so there generally are resources dedicated.
Yeah.
And then there's bereavement counseling for a year after the person
Oh, that's
dies.
fantastic.
So they follow up.
Yeah.
They call the family and talk to family members for up to a year after. That's part of the hospice benefit.
Where are places people can find resources about this?
So as far as having the conversations in general, the Institute for Healthcare Improvement has a really good, it's got conversation, having the conversation. They all the resources are some variation on a conversation. That's a really good resource, ihi.org. And then Beth Israel Deaconess Medical Center in Boston, affiliated with Harvard, has a really good just sort of checklist, and it has some scenarios and just ways to get the conversation started, because that's the hardest part. Once you get started talking, it tends to flow pretty well. And I'd also add that these things make it easier for your medical team too. And they're busy and they're stressed, and it's, we're people too, and it makes it easier for us to take care of you in the way that you want us to, rather than just kind of doing things. One other resource that I commend to folks in Tennessee is tn.gov. Our state has an advanced directive form. If you type in tn.gov and advanced directive in Google, it comes up in English and Spanish, and it's really good. It's a 2-page document. I really like it because it doesn't need a lawyer or a notary. So if you have 2 witnesses that are not named in the document, it's legal in the state of Tennessee. So you can get it notarized, but you don't need an attorney. And really what that advanced directive does is it does 2 things. It gives someone a healthcare power of attorney in the event that you don't have capacity to advocate for yourself or to make your wishes known. It also is a living will. And so that, living wills are fine. And if you have one, that's okay too. But there always is little language nuances and things depending on which lawyer wrote the living will, whereas this is a standardized form that's the same for everybody. And in my experience, this form is very similar to ones in other states. So I think if you took it to any hospital in the country, it would probably be recognized more than likely. So that's probably the number one. And even if you don't fill out the living will about what your wishes are, at least fill out who your agents are, because that's job number one.
Okay. Yeah, that's really as a member of a person's healthcare team, I am grateful to know this information. Grateful.
Of course, one of the reasons that a discussion like this is so important, I would think, is that not everyone has the advantage of time between a diagnosis to the end of their life. And so talking about these things now, even for healthy adults, these are discussions that need to be happening.
Well, that's true. I lost 2 grandparents from very sudden illnesses, heart attack, stroke, very short time period from illness to death. And then my grandmother and my mother had a long illness. The conversation is still applicable because there are decisions and even if it's hours before passing, that they're the same, some of the same questions arise. And there's an opportunity to explore this with family and with your medical team in advance so that you're prepared. When is the time to begin a palliative care discussion?
It's a great question. Generally, as with most things in medicine, earlier is better. And that's true whether you're having heart problems and you get a cardiologist involved early versus late. There's more stuff they can do for you. Palliative care is the same way. Palliative care can start really at the time of diagnosis of a serious illness or a life-limiting illness. So I see people who have just found out that they have cancer or a type of organ failure or dementia. So I meet them when they're finding that out, and those relationships have been really good. And sometimes they're better than the ones where I meet people where things are really late. And I have to meet someone, talk to them about what palliative care is, and then say, it's time for hospice for you. Like, I have to do all of that in a 30-minute window. That's hard. So earlier is generally better. And there's nothing about it that says, that your options are limited, or you can't have certain kinds of care, or you can't do this treatment because you're on palliative care. Even in the medical community, even among doctors, there's a perception that, well, they're on palliative care, so they can't do that chemo or a clinical trial or whatever. I've had patients on clinical trials for cancer that I've helped take care of, and support. And so it really can be a huge asset and really improve quality of life, even for people that don't need it anymore. There are people who I've treated for palliative care. They get treated, they're better, they're cured.
That's great.
They don't need me anymore.
Yeah.
And so that's cool.
Yeah.
Thank you. Once a patient has entered into really the dying process, whether it's in hospice or elsewhere, are there certain stages of it, and does it look the same for each person? Are there things universally families recognize?
Yes. So prognostically, when I'm asked to make an assessment about somebody's prognosis, the questions that I ask are they independently mobile? So can they get up and walk around and do things for themselves? And can they feed themselves, and can they converse or interact? Those three things, regardless of what the cause is, whether it's dementia, cancer, you name it, it's kind of a final common pathway for people. And those are big markers for timing of what's happening. You lose your mobility, that's a big deal. And a lot of people, even in medicine, don't recognize what a big deal that is. And so that's one to really key in on is losing your mobility or your ability to care for yourself, to go to the bathroom by yourself, all of these things that we take for granted, but they're really important for prognostication and figuring out where somebody is in their journey. As far as the immediate end of life, generally, if people are not eating and drinking, and I know that's one of the questions we were going to talk about, because that's one of the biggest issues that we face when people are dying is you got to give them food. We're in the South, right? We got to feed them. Somebody's sick. Here's a bunch of casserole. And so one of the things that I have conversations with almost daily about is what that process is like for people. And what we know in general is that eating and drinking is not eating and drinking is not distressing when someone is dying, because the body is trying to stay alive. And if you think about it, you don't need to eat to live moment to moment. You do need to eat to live, week to week, month to month, longer term, but you don't need to eat to live in the immediate sense. And so when you eat, it takes resources. And so if your heart, lungs, kidneys, liver, brain, they need that blood flow, and they can't afford to divert any blood flow to the stomach. So the body actually says, and if you ask people that are really sick, I'm not hungry. I'm not hungry. Usually dry mouth is a really tough symptom, but I usually tell people, get your favorite drink, whatever it is, put it on a sponge stick and, have at it. And that works. That's worked every time I've done it. And I've done it a lot. So generally, but it's part of the process of shutting down. And I think it's the way we're made. I'll be honest, that's what I believe. That it's protective in a way. When your kidneys fail, generally you're not hungry or thirsty because your body's saying, I can't handle any more stuff. But sometimes in medicine we ignore that and we do more stuff. So, that stage when people are not eating and drinking, generally once they stop eating and drinking, that's a 7 to 10 day process. So just to give you a time frame, usually for folks that don't have mobility, that are not communicating and doing any self-care without aggressive measures. Again, that's a key distinction because, if somebody's in the hospital, we can keep them alive a long time. But if they're at home, or they're on what's called comfort-focused care, generally, if you're not moving around, that's a month, 6 weeks, something like that. So, and then as you get into the immediate end of life, there are some things that people hear about. Maybe the death rattle. People have heard about that, the breathing where it makes a rattling sound, your secretions. Part of that is because your body's just not processing things. You're not swallowing. You're not doing the things that we all do with the saliva in our mouth right now. And so, that generally is more distressing to us, the people around it, than it is the patient themselves, at least what we know about it. The other thing is breathing may become irregular. People may stop breathing and have pauses in their breathing, and that's generally normal. And that's generally not something that people are aware of when they're dying. They're breathing from their brainstem and not from their frontal cortex. And so that generally, I think, is protective. And so it's not something, it's hard for us and the family and me. I'm like, gosh, that doesn't look pleasant. And there are things that we can do about it, but in general, and I'll say more about what I believe people are experiencing at end of life whenever.
Okay. Well, I think this comes up a lot because the value of these conversations is to prepare the family for some of these things that their loved one may not really be experiencing in the same way.
Yes.
In my job, I'm frequently asked to do a procedure to place a feeding tube in a patient. And in an end-of-life care situation, that question often comes up, well, if, my loved one is suffering because we're not giving them nutrition. And I love what you said because the families suffer and the loved ones suffer, but it is not believed that the individual is suffering.
Yeah.
But treating that with giving nutrition artificially, not by chewing and swallowing, can prolong that person's life for a long time. And so to what end is it prolonging that life? These are discussions that each individual and their family have to grapple with. And the earlier the better.
In general, level of awareness declines as your body shuts down. But I will say there is some level of awareness, even if it's just an awareness of the people in the room, a voice, a touch, because I've seen cases where people were unresponsive for a week. We were sitting there and then somebody comes and flies in, a child, a friend, somebody comes in, they hear that voice and they open their eyes, or they do something and they haven't done anything in a week. Now they don't necessarily get better, but we know that there's a connection. I believe very strongly that it's more of a transitional process. It's not you're here and then you're there. It's you're kind of here and kind of there, and you get more there and you're less here, but you're still here, you're here, because I've just seen too many instances where people really respond to somebody that's hardwired into their brain. They can't hear me anymore, which is probably a good thing, but they can hear their family and the people they love.
So you're encouraging family members to talk to them?
Yes,
and
even
engage.
if they're not responding in the way that you want them to, because I always tell families, I said, the best medicine I've got is you. I said, all the stuff that I'm doing, that's just a sideshow. The real medicine that's going to make them feel better and feel loved and at peace is hearing your voice and hearing music or anything that's comforting to them. I've heard people play, death metal, and I've heard people, play Muzak and, and talk about all sorts of funny stories and sad stories and all points in between. But I've seen people benefit from that. So that's an important thing that I want people to remember when somebody's dying, even if they're not responding in the way you'd like for them to. They know you're there.
Okay. What I've been asked before about terminal delirium. What is that? Terminal agitation.
So terminal agitation is a phenomenon where patients or folks that are dying have some form of altered mental status. Delirium in general means sort of a waxing and waning level of alertness. It can be hypoactive delirium where you're asleep and you don't respond. It can be hyperactive delirium where you are, wild. I've seen all variants of it, and it's pretty impressive when you see it. But it's also helpful to know when you see it too.
Yeah. Do you think patients can say things that they normally might not say to family members?
Absolutely. Yes, I've seen that on many occasions where people will say things, and really for folks with dementia, a lot of times you see that happen where people. That my grandfather just jumps out to me because I don't think he ever swore in his life, and then he got dementia and he cussed like a sailor, And so, it's jarring, it's very jarring, and it can be scary to see your loved one in that state, and so
I think it can be hurtful.
Yes,
they're hearing things that they don't normally hear, and you have to put the caregiver, the family member has to put themselves in context that this is not their loved one speaking, right?
Yeah.
It's different.
Yes.
Yeah, I'm glad you brought that up, actually. I hadn't heard the term terminal agitation until last year, and was with a congregant who was in hospice care, and there were some really uncharacteristic things happening I knew that he was nearing the end of his life, but it was obviously distress, but then also some things that just weren't at all like this person. And the hospice nurse, this is where a hospice nurse, I think, is so well trained to deal not just with the patient, but also with the people who are with them. And she came and she said, that's terminal agitation. This is normal. And it was a comfort, actually, to hear her explain that to me. And because I was thinking, what's going on here? I mean, knowing that it was part of the process, but still not used to hearing this person talk this way.
One of the ways I talk about it is it's just another system shutting down. And sometimes it shuts down in ways that are really, action-packed, and then in other times they're very calm and quiet.
Right. Well, part of this discussion also is care of the family. There's grief on the side of the family, clearly after their loved one passes, but during this process. And so some of these things that can be said or done that are not that are their cognitive, their loved one's self, their consciousness shutting down, can be hurtful. And I think it's important to understand that for people. And then I wanted to talk a little bit about, the grief of family. Is it the, Kubler-Ross cycle? Is it the same thing as grief for all families? Does it look different for individual families? How can their culture affect that? Because especially during the dying process, I occasionally see when different members of the family are struggling with grief, it can change the dynamic of the process for the patient.
Yeah, definitely. Grief is a part of all of this. Grief is a part of life, and I think that's one of the things that we ignore at our peril or try to minimize at our peril. I think in medicine, and particularly in the part of medicine that I work in, is palliative care. When somebody has a serious diagnosis, there's a grief there because you've lost something that you imagined, or somebody that you were going to be, or something you were going to do, or fill in the blank, whatever it is. That's a very real grief. That's just as real as losing a person, and so people recognizing that as people are going through the process, and not just, but also, unresolved grief or unresolved issues, death and serious illness don't generally make those better. So it's not like, it's unifying for families that were already pretty united. It can be very divisive for families that are divided. And so that's another reason in my mind to talk about these things early and try to get a plan together.
Eric, you mentioned the grief process, and I think what we're talking about here in a big part is about creating margin when possible so that grief can be done well, if that makes sense. That's a strange way to say it, but we want to be able to grieve well. We're going to grieve in some way, regardless of the circumstances. We're going to grieve in some way. And so if we've got the margin, whether it's anticipatory grief because we've got a diagnosis that we know is not hopeful, or whether or not it's the actual loss, that process has to move forward. And the more bogged down we are with all of the things that we have to do around that, the harder it's going to be to do that, and the longer it's going to take. You mentioned Kubler-Ross. The stages are so helpful to know, but it's pretty widely accepted at this point that it really is kind of shock followed by chaos, right? It's unpredictable.
Yeah.
The stages are there. They're not linear. Yeah. No one's going to go through them the same way as someone else. So no two people, even with the same loss, those two people are not going to grieve that the same. There's so much that goes into it. What's my relationship with that person? What are the complications around the illness or the circumstances of the death? All of those kinds of things come into play.
So once again, we're highlighting the importance of an honest and open discussion about these things early, and how it can prevent problems in the future.
And it's doing that in order to give grief its proper space, its margins. That was the word you used to do its work.
Right. Well, I'm wondering how we as believers can approach these situations with patients and families. How can we support, how can our faith, how does it inform us, and how can we help in this situation?
Those are great questions. And I think it is important to realize that, speaking spiritually or theologically, that starting in Genesis chapter 3, sin entered the picture, death entered the picture. So we've had to contend with this ever since then. Not at the very beginning. That's not the way it started out. But now we have to contend with it. So for now, in this season, death is a part of life. And that is something important for us all to remember. So if we trust as believers that God loves us, if we trust as believers that Jesus said, I am the resurrection and the life, and he who believes in me shall never die, if we believe that there is life beyond this life, then the whole question of transitioning of care takes on a different light. The question of transition of care can be frightening if we're afraid of death. But it doesn't necessarily have to be frightening if we realize that it's part of the process and that we can trust that our loved one who is close to dying is going to be resurrected and is going to see eternal life.
Hope.
Our faith and our hope in Christ can transform our view of dying. Right? That it's not a dark tunnel that's the end of the road. It's a transition between this life and the next life because of our hope in Christ, who said, I am the resurrection and the life. Death is not the end. And this is where I'd like to mention a doctor friend of mine that I won't name because I didn't ask permission to tell this story, who's now a believer. But earlier in his life, he worked in an ER in a hospital in another country, not as a believer. And he said when he saw families with patients who died traumatically, unexpectedly, it was very dark because to them that looked like the end. And then when he moved here and did the same type of work where there were a lot of believers that he encountered, when their loved one died, it was a totally different experience because the family knew and had the faith that that was not the end of their loved one's life. That it was a
I would agree with that.
Yeah.
It seems to be different.
It's different.
Mm-hmm.
Yeah.
You know, I think it's worth, you mentioned that death isn't the end for a believer, but illness and suffering is also not the end of the Christian life for a believer, right?
That's right.
So as a living Christian, asking that question as we're encouraging people to make these plans, part of the guiding questioning should be things like, how do I continue to serve and glorify God even in illness, even in terminal illness, even in suffering, even at the end, and let that sort of be one of those things that we are asking ourselves as we plan.
Right. One of the catechisms that we talk about at our church is the chief end of man is to glorify God and enjoy Him forever. And if you really believe that, that includes during illness, that includes the end of your earthly life, that includes dying. That's part of that would be part of the question then. Am I continuing to glorify God with my life? And that may be a question for the patient and for their loved ones to help answer that question of what kind of care they're receiving. What's the end of this care? Again, is it life-saving or is it merely life-sustaining? And is there hope of that person achieving some sort of function and glorifying God with their life in a conscious fashion? or is it merely keeping the heart and the lungs working?
Yeah.
There's not an easy answer to that question.
that's tough.
And by no means are we implying that there's some spiritual answer to the question, because every family, every loved one, every patient's going to be different. And it's also fine to still fear dying and death, even if you're a believer.
Yeah.
It's unknown for all of us.
Right.
And that can be scary. We don't have to fear it, but it's okay if we do.
That's a great point.
Yeah.
I was thinking, I almost teared up when you talked about that, about people glorifying God in suffering and in this process. I can think of many people that have witnessed to me and just glorified God in the way they treated other people, the way they approached it. It's like, well, I got another day, so that's cool. And thank you, Jesus. And just, it's so humbling to be around that. And I've had people do that. So many people do that for me in my work. That's one of the most rewarding parts, is to see that just because your body has changed, and I tell people this all the time, your body changes, medically things happen, but your faith and your family, those legs are still there, and you can still, and I've just seen people. I remember one lady that sang. She had a beautiful voice, and she laid in bed and sang hymns, and just everybody. It changed the unit. I mean, it changed everybody, believers, non-believers. People were like, "That's awesome." And so, I think that's important to remember, that we all go through this, and that God can still use our gifts. They may look different than what we thought, but I've been a beneficiary of that.
We have a friend who is 85, and he had a stroke a few years ago, and he's in a rehab facility, and most likely he may never leave that facility, but he teaches a Bible study every Wednesday, and then he attends another Bible study every Friday. He faithfully watches our church service online, and he is being used and glorifying God with his life exactly where he is. And every time we go see him, it's just amazing. I thought of a couple of other things about how do we best care for the family. I think we can remind them, first off, that God loves them even more than we do, even more than they do. And that in the midst of whatever illness or complications or the process or the transition, God's love is unceasing and unending, and it's not stopping no matter what the results are, right?
Yeah.
It's not, God's love is not, that's the one thing out of this whole scenario that we know is unchanging, and that we can have confidence in that.
Right.
This is where I'd like to recommend this book. It's called Between Life and Death. It's written by a doctor, Catherine Butler, and it's an excellent book. It talks a lot about everything that we've been talking about. And in one of the early chapters, she talked about 4 key principles that can guide us as we consider end-of-life care. One of them is the sanctity of mortal life, that we are made with finite limits. We are mortal, and we're made in the image of God. We're fearfully and wonderfully made. And she had a comment that the sanctity of life mandates how we respond to both ends of human life, caring for the unborn and caring for those that are close to the end. It's our responsibility. We have to acknowledge God's authority over life and death. God is sovereign, and He holds the power over life and death. And as believers, we're grateful that with Jesus' sacrifice, crucifixion, and resurrection, that He has defeated that final enemy. And we can be...
He's been through it himself.
He has been through it himself.
Yeah.
He's shown us the way. And we are encouraged to deal with mercy and compassion towards gosh, family, caregivers, patient, knowing that everybody's story is different, every situation is different.
I think that opportunity where clearly someone's suffering is an opportunity to show them the love of Christ.
Yeah. Yes, and to be there, to be with them in their suffering.
And to be faithful to that to the end, which I think
Right.
is
Yes.
a big part of
Yeah.
it. Yeah.
The last of those 4 tenets I already mentioned was just that hope in Christ can transform our view of dying.
Mm-hmm.
You know, that it's okay to be fearful, but we don't have to be afraid of death itself. Jesus has delivered us from the permanence of death, I think is the way she phrased that, and I really like that.
Yeah.
We have been delivered from the permanence of death. It is merely temporary.
Well, how can the village chapel support people and families?
Making sure people know they have an open door to ask questions and ask for help, whether it's physical, needs and rides to the hospital or caring, or both pastoral and counseling.
Yeah, I think on any side of this process, whether it's anticipating loss or whether it's experiencing loss, that can really isolate a person. I think they can feel really alone in that.
Yes.
And so understanding that they have a support group and finding out who those folks are and kind of rallying that help, I think as quickly as possible really is key. And in a church, we obviously want people to feel connected to their small groups and to their home groups and to their men's and women's groups and obviously to pastoral staff. But yeah, that's one of those places where we don't want anyone to feel like they're going to walk through something like that without the resource of support and care.
Yeah.
And you guys have vocationally, and well, I guess vocationally for us too, it's just a different vocation, but we definitely have had experience of being at bedsides with people in the very last moments. I've had family members where I was there as they passed, but it is a magnificent, if I can use that word, thing to be able to be in those moments with congregants, family members, patients.
When that veil is so thin.
Oh, it is so thin, and you just have such an awareness of both sides of the veil.
Yeah, it's an honor.
It is.
Honestly.
That's the word.
That's
It's
what it
an
feels like,
honor
isn't it?
and
It's
a
an honor to
privilege.
be there. Yeah.
What an opportunity to talk about this and to allow families to begin a discussion during times when it's not a crisis. The emotional stress associated with end of life can be so high that it compounds decisions and makes it even
everything
more
hard.
difficult. When there's some preparation in advance, it's still difficult, but it's a little smoother.
Yeah. You're able to just focus on your loved one.
Exactly.
Yeah. And realize that you are going to go through grief, but you're able to focus on your loved one.
Right.